Hi, I'm Dr. Don Lanza.
And I'm Dr. Alla Solyar.
We are rhinologists practicing at the Sinus and Nasal Institute of Florida in sunny St. Petersburg, Florida. We also have appointments at the University of South Florida in their Division of Allergy and Immunology.
We have been tasked with creating a video book chapter on cerebrospinal fluid leak, diagnosis, and evaluation.
We'd like to thank the editors, Dr. David Goodis, Jivian Lee, and David Kennedy for giving us the honor of this invitation. Thank you.
Our outline is as follows. We're going to go over disclosures, key points, background, history and physical, presenting symptoms, confirming the diagnosis of CSF rhinorrhea, localization of skull-base dehiscence site, intraoperative localization of CSF leak.
We have nothing to disclose.
Our key points are as follows. Post-traumatic clear rhinorrhea is a cerebrospinal fluid leak until proven otherwise. Unilateral clear rhinorrhea is a CSF fistula until proven otherwise. Never perform in-office biopsy of polyp that can be associated with skull-base dehiscence without imaging it first. Rhinorrhea positive for beta-2 transferrin is the gold standard for diagnosis of CSF leak. CT, T2-weighted MRI, and nasal endoscopy are complementary to evaluate the presence as well as to localize and treat the source of cerebrospinal fluid leak.
Background.
Rhinorrhea is an excessive nasal discharge and is commonly related to inflammatory conditions, whereas cerebrospinal fluid rhinorrhea is a potentially lethal condition that results from an abnormal communication between the subarachnoid space and the sinonasal cavities. This communication permits drainage of CSF into the nasal airway, and it can permit ascending infection intracranially arising from the respiratory tree. CSF rhinorrhea can be difficult to distinguish from rhinorrhea of other etiologies. This condition can occur following trauma, surgery such as sinus surgery and from neurosurgical procedures, or may have a spontaneous etiology, such as in the case of benign intracranial hypertension. Two important criteria in the safe management of CSF rhinorrhea include confirmation of its presence and its localization.
Both are challenging, especially when the leak is intermittent or not inducible. Unilateral clear water-like rhinorrhea is a CSF leak until proven otherwise. Respiratory epithelium of the sinonasal cavities typically produces an estimated 0.5 to 1 liter of mucus per day, and in a respiratory tract infection, it increases up to 2 liters. Abnormal rhinorrhea is commonly seen in disorders of allergic and non-allergic rhinitis. In cases of rhinitis, ipratropium bromide nasal spray will diminish the rhinorrhea, however, it will not be effective for CSF leak. Symptoms concerning for CSF rhinorrhea are new onset unilateral clear water rhinorrhea, salty metallic taste, headache associated with rhinorrhea, cough, pneumonitis, unilateral fullness popping or crackling signifying possible otorhinorrhea, as well as a reservoir sign.
From a historical perspective, CSF rhinorrhea was first described by Galen in 2nd century AD as a normal periodic release of CSF into the nose via the ethmoid and pituitary regions. And for centuries, it was thought that there was a free communication between the brain and the nose, until Conrad Victor Scheider, a 17th century anatomist, demonstrated that nasal lining produces mucus or catarrh and not CSF. By late 1800s, St. Clair Thompson described a series of patients with nasal CSF leaks and coined the term rhinorrhea. Dandy is credited with the first surgical repair of a CSF leak via frontal craniotomy approach in 1926. In 1981, Wiegand reported on the use of the endoscope to assist with the repair of skull-base defect occurring during ethmoidectomy. Subsequently, multiple authors, including Lanza et al., reported on the potential advantages of an endoscopic approach in the management of CSF leaks which is now the standard of care.
Definitions: reservoir sign, halo sign, otorhinorrhea, pneumocephalus, handkerchief sign, washout sign, and Queckenstedt test are all listed here for your review. The reservoir sign: this occurs when a patient arises from a recumbent position, resulting in a rush of clear fluid from the nasal cavity. This can result from CSF pooling in the sinuses, typically within the sphenoid, or sometimes rarely within the maxillary. A halo sign: a clear ring surrounding a central blood spot on bed sheets or tissues or filter paper, can serve as a first clue to CSF leak, especially in the setting of trauma. Otorhinorrhea, already mentioned, is middle ear mastoid source of CSF leak, drains through the eustachian tube into the nasal cavity. Pneumocephalus is the presence of air within the intracranial space, and a handkerchief sign: discharge from the nasal cavity blown into a handkerchief and allowed to dry. If it is a CSF leak, it will not stiffen, it will remain soft, whereas mucus would stiffen. Washout sign is visualized intraoperatively: clear water-like CSF rinses away blood. And the Queckenstedt test is performed by compressing the jugular veins in the neck, allowing intracranial pressure to elevate, thereby promoting the CSF rhinorrhea.
Here's some abbreviations defined. HRCT is high resolution computed tomography. MRC stands for magnetic resonance cisternography. CEMRC is intrathecal gadolinium enhanced MRC. CTC is computed tomography cisternography. RNC is radionuclide cisternography. IF is intrathecal fluorescein. With regard to the most common cause of CSF leak, it is head trauma. Less frequent causes are sinus surgery, congenital etiology, erosion from sinonasal or intracranial lesion, prior skull-based radiation, and increased intracranial pressure.
Here's a patient who was 51 when she first presented with mucosal melanoma involving the dura, cavernous sinus, left infratemporal fossa, and presented with left eye blindness the day prior to surgery. The patient undergoes a debulking with me at the Cleveland Clinic in 2002. She undergoes adjuvant therapy with University of Pittsburgh, and then undergoes proton beam. Postoperative result prior to packing removal is seen here, without any evidence of CSF leak or pneumocephalus, until the patient goes body surfing and she experiences CSF rhinorrhea as seen by pneumocephalus present here. This is 8 years status post-debulking. She eventually passes away secondary to distant meds, but survives her repair.
Spontaneous CSF rhinorrhea is a rare condition which can present without any remote history of head trauma.
The most common site of CSF leak from traumatic etiology are the frontal and sphenoid bone, followed by the fovea of the ethmoid and the cribriform plate. The vast majority of traumatic CSF rhinorrhea will resolve with conservative measures and may not require significant workup. Mincy in 1966, years ago, demonstrated a case series of 54 patients with post-traumatic CSF leak, with 85% of the cases closing spontaneously within a week of presentation. Patients with low-pressure CSF leaks can have them through defects along the tegment of the middle ear and rarely develop along the spinal column. A case in which this might occur would be in Ehlers-Danlos syndrome.
A coronal CT scan here demonstrating a skull-based dehiscence in the right epitympanum.
The most challenging of CSF leak to identify is the one that is very slow or not inducible.
Spontaneous CSF rhinorrhea is a rare condition which can present without any remote history of head trauma. More typically, it is associated with elevated intracranial pressures, such as in benign intracranial hypertension. Rarely in our practice we have seen postural orthostatic tachycardia syndrome with or without Ehlers-Danlos associated with CSF leaks. Identifying the etiology of intracranial hypotension and or hypertension typically requires integrated multidisciplinary approach, including neuroradiology, neurology, neurosurgery, ophthalmology, and rarely cardiology.
These are images demonstrating a normal optic disc with sharp, clear edges and the fuzziness typically seen around edema of the optic nerve seen in elevated intracranial hypertension, papilledema. These are MRI findings consistent with empty sella turcica, findings consistent with benign intracranial hypertension. Orthostatic headaches are caused by either intracranial hypotension or hypertension. Regarding hypotension, there's emerging concepts that spontaneous intracranial hypotension may mimic postural orthostatic tachycardia syndrome, and there's some literature supporting this. The postural orthostatic tachycardia syndrome, or POTS, refers to 30 beats per minute increase in heart rate or an absolute heart rate of greater than 120 beats per minute within 10 minutes of moving from the supine position in the absence of hypotension, arrhythmia, sympathomimetic drugs, or other condition. It is linked in some literature to spontaneous CSF leaks, and they have in common these symptoms: headache in the upright position, nausea, vomiting, lightheadedness, brain fog, and fatigue.
Pertinent past medical history includes history of head trauma, sinus surgery, including balloon dilation, neurosurgery, meningitis, nasal intubation or intranasal testing, such as with a COVID testing swab, obesity, obstructive sleep apnea, and history of CPAP use, their vaccination records and allergy test results, as well as history of sinusitis with bone loss at the skull base, such as from mucocele or allergic fungal sinusitis, as well as the history of radiation to head, spine, and skull base, and Ehlers-Danlos syndrome, and POTS.
Sinus balloon dilation can lead to complications as well, even though it's been promoted as being a very benign procedure. In 2022, the CDC advises pneumococcal vaccine for all eligible patients with CSF leak. Presenting symptoms. Clear fluid rhinorrhea is the most common presenting symptom and may be accompanied by headache that is positional, in most cases typically worse when upright. Hearing loss or tinnitus can be a sign of idiopathic hypertension. Hyposmia and olfactory testing is important if the defect is in the olfactory area. Patients may not realize they have a diminished sense of smell until after surgery, which could pose a dilemma.
Patient counseling when CSF leak is suspected is important. You want to discuss signs and symptoms of meningitis with them. They should be instructed on no nose blowing, no scuba diving, or flying in an unpressurized airplane cabin. You may want to initiate anti-inflammatory therapy such as with ipratropium bromide pending the results of the beta-2 transferrin testing. The signs and symptoms of meningitis include severe headache, nausea, vomiting, photophobia, knuckle rigidity, fever, mental status changes, seizures, and in cases of persistent post-traumatic CSF rhinorrhea, the risk of meningitis is 8.4% per year after the first 6 months, with higher risk in the first 6 months.
Active and inducible leaks are easier to identify and localize opposed to the slow and intermittent leaks. Active and inducible leaks likely pose greater hazards to patients for meningitis, whereas slow and intermittent leaks may take years to discover. This patient here, who had surgery performed elsewhere, presented with a unilateral clear rhinorrhea amidst her polyps. Allergic rhinitis, non-allergic rhinitis, rhinitis medicamentosa, chronic rhinosinusitis with polyps, and extraesophageal reflux also can present with rhinorrhea.
Important physical exam findings include middle ear effusion or bubbles seen on otoscopy, papilledema on ophthalmoscopy. Specifically, nasal findings will include accumulated fluid in gravity-dependent sinuses, such as in the maxillary sphenoid sinuses in people who have been operated on. CSF fluid may be collected or aspirated for beta-2 transferrin detection. With the patient leaning forward and utilizing a flexible fiber optic endoscope or even a 30-degree rigid scope in the nose for visualization, you may be able to see an approximate source of the leak site. Draining clear fluid may be seen in an olfactory cleft, sphenoethmoidal recess, or eustachian tube orifice. You may be able to see meningocele or meningoencephalocele on endoscopy, as well as pulsation in the suspicious areas.
This patient has a pulsatile area with pus, presented with headache and neck stiffness. When I suctioned away the pus overlying this encephalocele, the patient's headache improved. Findings on endoscopy may help corroborate findings on imaging, but alone is not sufficient in most cases to determine the site of a CSF leak.
Never biopsy a polyp that could be attached to the skull base without imaging it first. This is an example of a patient who presented with unilateral nasal polyp. The patient had a remote history of motor vehicle accident and had annoying bilateral clear water rhinorrhea. However, this polyp turned out to be a massive meningoencephalocele.
Confirming the diagnosis of CSF rhinorrhea. Anti-inflammatory trials pending beta-2 transferrin testing include medical therapy, possibly with systemic steroids, antihistamine, leukotriene modifiers, anticholinergic agents such as ipratropium bromide, PPI therapy, or H2 blockers for patients with postnasal drip and GERD-related symptoms. Antibiotic prophylaxis for patients is not generally recommended for patients who have sinus fractures. However, there is sparse evidence of perioperative use of antibiotics in the management of CSF.
Confirmation of CSF leak is important prior to pursuing costly and sometimes invasive testing. Glucose testing and ring sign are not very accurate tests and are not typically utilized. Additional tests will include beta-2 transferrin, beta-trace protein, and radionuclide cisternography. Glucose testing method is not a reliable clinical tool. It's possible to utilize glucose oxidase strips. However, the interpretation of results may be affected by contamination from tears, nasal mucus, and blood, and does lead to a false positive test. Active meningitis may lower glucose levels in CSF, leading to false negative test results. Therefore, this test is not recommended. With regard to the ring sign or halo sign, the CSF combined with blood may leave a ring or halo sign on white sheets or similar material. And this may be a clue to CSF leak, especially in a trauma patient. However, it's important to realize that CSF mixed with any other clear fluid can produce this sign. And because of high potential for false positives, both the ring sign and glucose testing are not advised for use in confirmation of CSF rhinorrhea. Beta-2 transferrin is a gold standard in diagnosis of CSF fistula. Beta-2 transferrin is a glycoprotein that is present in CSF. It is an important diagnostic tool and marker being present in CSF but not in nasal secretions. An important study by Wernicke et al. In 2004 looked at 205 beta-2 transferrin assays that were performed in 187 patients with suspected otorrhea or rhinorrhea, and the authors reported a sensitivity and specificity of 97% and 99% respectively. Half a ml of fluid should be collected for ideal testing. However, it's possible with a smaller amount of fluid. And Blyer et al. In 2011 demonstrated stability of CSF and ability to detect beta-2 transferrin in samples at 1 week after collection, kept either refrigerated or at room temperature. And this has implications for patients with slow or intermittent leaks. Additional multiple studies support beta-2 transferrin testing as a reliable, cost-effective test with minimal risk or harm to patient. Beta-2 transferrin false positives are rare, however may occur from issues as listed below. Beta trace protein test is a valuable and sensitive test, however it is not available in the United States. It is also present in high concentration in the CSF. It is produced mainly in the leptomeninges and choroid plexus. Its sensitivity and specificity ranges from 91 to 100% and 86 to 100% respectively. Renal insufficiency and bacterial meningitis can alter the levels of beta trace protein. Advantages include low cost and quick turnaround time.
Localization of skull base defects.
There are a variety of tools available for localization of CSF fistula with a wide range of degree of invasiveness, cost, and availability. The evaluation starts with in-office endoscopy, and once the CSF leak is suspected, imaging is important for diagnosis and perioperative planning. High-resolution computed tomography, or HRCT, may be obtained with or without the true coronals. There is magnetic resonance cisternography, or MRC, intrathecal gadolinium-enhanced MRC, known as CE-MRC, CT cisternography, or CTC, radionuclide cisternography, RNC, and intrathecal fluorescein, or IF. Image guidance with endoscopy may provide simultaneous confirmation and localization of the defect site, as some of the studies listed above. Common suggestive imaging findings include skull base defect, meningocele, meningoencephalocele, encephalocele in the pneumatized pterygoid recess as shown here, air fluid levels in non-irrigating patient, and empty cella suspected on CT but confirmed on MRI.
Here's a patient who was a 49-year-old Hispanic man, status post-motor vehicle accident 20 years prior with an identified skull base defect posteriorly on the table of the frontal sinus. This massive encephalocele extends over the decades that followed, posteriorly and inferiorly as seen on the sagittal image below. This was repaired endoscopically, transnasally, to resect the majority of the encephalocele, however, required a trephination approach for repairing the skull base defect because it was too high and not accessible for the delicate work required at the posterior table of the frontal sinus.
High-resolution computed tomography, or HRCT, is a common initial study for localization of CSF leak, allowing for evaluation of sinonasal anatomy, providing superb bony detail, and aiding in identification of bony defects. Opacification or air fluid levels in the sinuses may offer additional clues with regard to CSF fistula location. Excellent sensitivity has been reported from a cohort of 26 studies, averaging at 93%, however, with a specificity of just at 50%.
Look for subtle findings on HRCT as means demonstrated in a series of 15 patients, that in the absence of an obvious skull base dehiscence, opacification of the olfactory cleft marked the leak site with 100% accuracy confirmed intraoperatively.
Multiple additional studies of high-resolution computed tomography showed that intraoperative findings correlated well with the defects identified by HRCT in all cases. Additionally, rates of accuracy with regard to measurement of the size as well as the location of the leak were improved with thinner slices on the CT scan. HRCT has a low specificity. Not all defects seen on HRCT represent true CSF leaks, as well as some dehiscences seen on CT may occur naturally. In a recent systematic review and meta-analysis by Kim et al., the authors note a lower detection rate in cases of smaller skull base defects, measuring under 2 millimeters. They go on to state that fractures without obvious bone dehiscence in the ethmoid skull base and cribriform may be difficult to localize on HRCT. Furthermore, it may be difficult to localize source of CSF leak in patients with multiple skull base fractures. Because of the lack of specificity, multiple studies do recommend using a combination of HRCT and MRC.
Magnetic resonance imaging is typically performed with a standard T1 or T2 weighted image. The T1 contrasted studies may help identify critical intracranial pathology such as intravascular lesions such as aneurysms or intracranial lesions such as meningiomas. They may be reformatted into multiple planes and may be used for intraoperative navigation. This is more for localization used during surgery. However, a T2 weight MRI has benefits for localizing a CSF leak. Disadvantages include inferior resolution of bony anatomy and cost. MRC is a type of MRI that uses a scanning protocol with heavily weighted T2 images with fat suppression and image reversal, allowing identification of CSF leak flow through a skull base defect. MRC is a T2 weighted MRI which is devoted, and MRC is a non-invasive study that is useful for both leak confirmation as well as localization of skull base dehiscence. This is possibly given inherent bright T2 signal of the CSF passing from the intracranial space into the sinonasal cavities. This technique can enhance CSF signal through suppression and subtraction adjacent tissue signals without the use of IV dye or intrathecal injections. Identification of herniated brain tissue through the skull base defect. MRC is considered cysternography and may be confusing, although it is implied the use of intrathecal injection. It does not have intrathecal contrast injection, lacks the use of radiation, and may be more useful for soft tissue identifications, differentiating between a mucocele and a meningocele, which may be more difficult to identify or discern on a CT. The disadvantages of this type of study are cost, poor spatial resolution, lack of bony anatomy detail. High T2 signal for inflammation may result in false negative findings.
Here's the MRC protocol from an article by Sillars et al. From 1997 and may be used for your implementation of this type of study in your radiology department. Additionally, here's a list of practical points for implementation of MRC from our neuroradiologist, Dr. Glenn Cole.
Intrathecal gadolinium-enhanced MRC, or CEMRC, aids in the diagnosis of CSF fistula with demonstration of T1 hyperintense gadolinium contrast extravasation from the subarachnoid space into sinonasal cavities. However, this is a truly invasive study with additional risk of lumbar puncture avoided by regular T2 weighted MRC. However, it also is felt to be safe and effective. Studies report a sensitivity ranging from 61 to 100% and a specificity of 66 to 80%, with a positive predictive value of 76% and a negative predictive value of 93%.
Kim et al. Report that with exception of transient headaches, no side effects of CEMRC were observed during the long-term follow-up period of approximately 4 years. Authors attribute this to low-dose gadopentate diglumine injection. Kim et al. Report a sensitivity of 93% and C et al. Report a near perfect sensitivity and specificity of 99 and 100% respectively based on 6 cohort studies. Studies comparing T2 weight MRC and CE MRC reported greater efficacy of the latter in identifying the skull-base defects.
CE-MRC technique as a protocol from Delgadio's paper in 2015 is included for completeness sake. It's for your reference and review and utilization and management of the most difficult to identify sources of CSF rhinorrhea. Any intrathecal study is advised against unless absolutely necessary.
Computed tomography cisternography was considered to be standard of care for many years, but has given way to less invasive and more accurate studies. This procedure requires a lumbar puncture as it involves intrathecal injection of contrast medium followed by CT scanning to identify the skull-base defect site in the location where the contrast extravasates in the sinonasal cavities. As with MRC, it can be used for leak confirmation as well as localization. Oakley et al. Report on 12 studies that included CTC imaging showing sensitivity ranging from 33 to 100% and specificity of 94% and accuracy of 33 to 63%.
Computed tomography cisternography is a potential superiority to high-resolution CT with regard to CSF leak. There had a low negative predictive value as similar to CT. Additional disadvantages include high viscosity iodinated contrast agent, possibly hindering extravasation into the fistula, may leave small defects undetected. Inferior sensitivity as compared to MRC or CE-MRC, according to Oakley in 2016, and CTC may also have these or morbidities associated with lumbar puncture as well as hypersensitivity reactions to contrast medium and high radiation dose. Depending upon the study, contrast dye included 99M technetium DTPA or iohexol. Radiation dose may vary.
With regard to radionuclide cisternography, the radioisotope is injected intrathecally through a lumbar puncture, and pledgets are inserted into the nasal cavities for several hours at a time and then removed to measure the radioactive tracer. Indium-111 diethylene triamine pentaacetic acid is the only radiotracer isotope approved by the Food and Drug Administration to evaluate CSF leaks. However, TC99M DTPA is preferred due to better image quality and lower costs. This is an invasive study with potential risks related to lumbar puncture and intrathecal injection. Also, it is not tolerated as well by patients because of placement of pledgets in the nasal cavities.
Radionuclide cisternography is better thought of as a confirmatory study and diagnostic study than a localizing study, as the tracer may exit the skull-base dehiscent but make contact with a pledget at a separate site, for example, near a eustachian tube orifice. It has a sensitivity of 76% up to 100% and a specificity of 100%. Compared to beta-2 transferrin and beta-trace protein, this is more invasive and expensive and less accurate test. It should not be employed as a routine test for confirmation of CSF leak. If a nasal beta-2 transferrin is negative, it is advised to repeat another one before proceeding to a radionuclide pledget study.
Moving on to intraoperative localization of CSF leak. Localization is critical for successful treatment. Surgical intervention is paramount for management of persistent CSF rhinorrhea because of risk of developing a respiratory tract infection that can lead to meningitis and less commonly disabling symptoms that are reported as in low-pressure headaches. Endoscopic approaches are now the standard of care, demonstrating high levels of success and low levels of morbidity. Localization of skull-base defect is paramount for successful surgical repair, and failure to accurately localize the site of a leak can lead to surgical failure.
Intrathecal fluorescein is an off-label use that involves injecting this fluorescent dye intended for intravenous use intrathecally, not to be confused with the ophthalmic fluorescein also available commercially. Oakley et al. Reported on 15 studies using intrathecal fluorescein reporting identification of CSF leak in 46 to 100% of cases. Z et al. Reports 2 cohort studies that involve intrathecal fluorescein in 76 patients. One study reported perfect sensitivity and specificity, while the other reported sensitivity of 92 and incalculable specificity.
It is important to obtain a separate consent on its potential adverse effects, as it's specifically stated on the bottle that it is not for intrathecal use. Potential adverse effects include lower extremity weakness, numbness, tingling, and paralysis, seizures, cranial nerve deficits, as well as death. It is important to discuss with your patients that adverse effects typically occur with high doses, but this intervention appears to be safer at lower doses. We use the lowest dose and concentration, 0.05 to 0.1 cc's of 10% fluorescein for IV use, diluted in 10 to 15 cc's of patient's own CSF. Intrathecal fluorescein is slowly infused via lumbar drain over 20 minutes with patient in Trendelenburg position to prevent pooling of intrathecal fluorescein in cauda equina. A blue light filter may be helpful for visualization of the intrathecal fluorescein coming out through the skull base defect. A retrospective chart review of intrathecal fluorescein use in 54 patients identified that most side effects were nonspecific, transient, and not likely caused by intrathecal fluorescein. 3 of the patients experienced transient lower extremity weakness and numbness, however difficult to prove that this was caused by fluorescein. No patients in that study experienced seizures. Topical fluorescein may be placed intranasally, and when this is mixed with CSF, it changes color to identify the site of a defect. 3 studies addressed use of topical fluorescein for detection of CSF rhinorrhea. 100% sensitivity was reported. However, there are no control studies were done to determine the rate of false positives.
Here is a patient who had an endoscopic approach to the management of a meningocele involving the left optic canal. This video is intended to give you the sense of how the findings on imaging can appear endoscopically and be coordinated for the patient's care. This is a postoperative CSF rhinorrhea at an outside hospital in patient with chronic rhinosinusitis with polyps. T2 MRI weighted images shows penetration of the CSF into the right posterior ethmoid. Additionally, imaging shows post-contrast MRI with cerebritis involving the gyrus rectus. Here is an endoscopic draft 2B patient who suffers from iatrogenic CSF leak. This patient may have been a better candidate for transeptal frontal sinusotomy. Note the patient's orbit and the osteoneogenesis near the right orbit. Here's orbital fat exiting in the left frontal cavity and a washout sign seen along the left middle turbinate strip or remnant. This is a patient who has multiple massive frontal sinus mucoceles who has experienced iatrogenic CSF leak while using a frontal sinus soft tissue shaver. This tends to be more a high pressure leak.
Opening pressure. Spontaneous CSF leaks are associated with benign intracranial hypertension. Obtaining an open pressure prior to initiation of procedure may be useful to help make the diagnosis of benign intracranial hypertension and help guide subsequent care. However, in some cases, the raised intracranial pressure may not be evident until after the defect is repaired. It may need to be rechecked once the leak is closed. An opening pressure of 25 is seen in this case of an obese man with spontaneous CSF leak. An external ventricular drain may be placed in cases where a lumbar puncture may not be performed. Economic implications of testing. In addition to the differences in availability, risk of adverse effects, sensitivity, and specificity, various imaging modalities also differ with regard to cost. It makes more sense to use beta-2 transferrin testing, which costs only $90, and avoid the use of radionuclide cisternography, which is expensive at $2,800, and still, in most cases, requires additional testing to identify the site of the leak. The cost of each diagnostic modality was determined based on reimbursement data published by Centers for Medicare and Medicaid Services. The reimbursement rates for HRCT, MRC, CTC, and intrathecal fluorescein were $141, $743, $580, and $152 respectively. Both from a sensitivity and economic standpoint, it makes sense to obtain beta-2 transferrin and HRCT if CSF leak is suspected.
Here's a flow chart for the diagnosis for suspicious CSF rhinorrhea. If a patient is beta-2 transferrin positive and HRCT positive, we recommend a preoperative MRI and perform endoscopic repair under general anesthesia without fluorescein. Beta-2 transferrin negative and HRCT positive for a patient with unilateral clear rhinorrhea, we would use an MRI or an MRC. Repeat beta-2 transferrin would be positive or negative. If it's negative, you'd have to explore under general anesthesia with fluorescein. However, if it's positive, you might be able to perform the testing without fluorescein. Beta-2 transferrin positive and HRCT negative, get an MRI-C, and if that's negative, repeat beta-2 transferrin with background measurements. Background measurements refers to getting patients' blood at the same time as CSF collection or the putative CSF collection. Observe the patient if they're both negative. And then beta-2 transferrin negative, HRCT negative, observe the patient. This would be the direction of the care. And if the patient is negative but has clear rhinorrhea, you might consider using ipratropium bromide to see if it alleviates it, or a trial of acetazolamide for spontaneous or intermittent or very slow CSF leaks documented by testing. Here's the stepwise approach to the diagnosis of intraoperative localization of CSF leak in this 63-year-old overweight woman with 3-month history of inducible right clear rhinorrhea, denies head injury. This is her endoscopic flexible fiber optic endoscopy, demonstrating her leak, dragging the flexible scope anteriorly in her nose is far more comfortable than doing this with a rigid scope. Note the image quality is further improved when a 70-degree telescope is introduced. You can see the fluid collection in the right anterior olfactory cleft. The patient is leaning forward while this is being performed. Here's a view of her CT, demonstrating at the location of the arrow where the leak was suspected. Then the patient has an MRI to confirm no evidence of any other concerning findings. It corroborates the findings. T2 coronal MRI. Again, the area of suspected leak. Being right-sided, note that there's no evidence of empty cellus syndrome or middle ear fluid seen on the MRI. Then the patient is brought to the operating room with concurrent image guidance and localization. Notice two dots, one blue and one green, seen on the sagittal image, now the coronal image. And when they get close to one another, and there is the CSF leak seen endoscopically in the upper right-hand picture. And this is how this patient had her small meningocele and localized, identified, and documented.
Summary.
Two most important tests used to confirm the diagnosis and localize the skull-base defects are beta-2 transferrin and high-resolution CT of the paranasal sinuses, respectively, and should be used initially in order to avoid the morbidity, discomfort, and cost of more invasive methods.
Endoscopy, in-office and intraoperative, is critical and complementary to all imaging studies.
Initiate pneumococcal vaccine as advised by the CDC as soon as reasonably possible once a diagnosis is confirmed.
MRI is typically included in the assessment of patients with suspected CSF rhinorrhea. While T2 MRI is utilized to identify CSF, contrasted MRI is also obtained to carefully evaluate the surrounding anatomy, looking for vascular aberrations, signs of benign intracranial hypertension, and to rule out possible tumors.
Intrathecal contrasted MRI, radionuclide cisternography, as well as cisternogram with a CT, as well as intrathecal fluorescein, are typically unnecessary and are advised against, except in the rarest of cases, given the availability of accurate, safer, and less expensive alternatives.
CSF rhinorrhea is an interdisciplinary problem best identified and localized with the assistance of your neuroradiologist.
Here is a list of suggested readings.
Our references are as follows on these 2 pages.
With that, we'd like to thank Dr. Kennedy, Dr. Goodis, and Dr. Lee once again for our invitation to share our experience and thoughts on how to diagnose and evaluate CSF rhinorrhea.
Thank you for watching.
Thank you.